Welcome to our live webinar titled PNH, Diagnosis, Management, and Connection to Aplastic Anemia. Thank you for joining us. My name is Lee Clark, patient educator, and I'll be moderating the presentation today. As we get started, I'd like to recognize the generous support of Alexion and Apellis, and the generous support of our patients, families, and caregivers for supporting the webinar program today. Due to the high volume of teleconferences on the internet, it is possible you may lose your connection during the program. If you are unable to view the webinar online, you can call in to hear the audio portion of the program using the call-in number in your reminder email. Today's program will be archived to our website within 2 to 3 business days. You will be notified by email when it is live and ready for viewing. Immediately following the presentation, there will be a question and answer session. Please feel free to submit your questions or comments at any time during the presentation. To submit a question or comment, open the Q&A window in the lower part of your screen. Type your question or comment in the small text box window, and when you have finished typing, just hit enter. We will do our best to get to all questions today. When asking questions, I do ask that you do 2 things to help me manage the incoming questions. First, submit your entire question all at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your personal health care. Today's specialist, Dr. Charles Parker, is a professor of medicine in the Division of Hematology and Hematologic Malignancies, Department of Internal Medicine at the University of Utah, the Huntsman Cancer Institute, and the George E. Whalen VA Medical Center, Salt Lake City, Utah. Dr. Parker received his MD from the University of North Carolina, Chapel Hill. He received his training in medicine and hematology from North Carolina Memorial Hospital, Chapel Hill, and Duke University. With that said, it is my pleasure to welcome Dr. Parker.
Okay, good morning, everyone. Today we're going to talk about PNH, focusing on the diagnosis and management, although we will talk about the pathophysiology as well. And also, toward the end, we'll discuss some new treatments that are under development and actually in clinical trials, in humans, most of them. So first slide, please. I was going to start off with a case presentation. This was a patient who was 31 years old at the time of presentation to a local emergency room. She was found to have a hemoglobin of 3.8, hematocrit of 12%, so obviously very anemic. Her white count was at the lower end of the normal range, as was her platelet count. So this was an isolated anemia, although there was evidence of some marrow compromise. LDH was markedly elevated at 1872, with the upper limits of normal being 240. Reticulocyte count was also elevated at 11.5%, and the hemoglobin, the haptoglobin, which is a marker of hemolysis, was less than 6 milligrams per deciliter. A test was done to make the diagnosis, and I've given these options for what possible tests could have been done. One would be the Windocell test. Another would be the Coombs test. Ham's test is another. And then peripheral blood flow cytometry for GPI-anchored proteins. So the Windocell test, next slide, was used initially in the diagnosis of PNH, and in this case, the point that of this illustration is that the urine, the first voided urine of the morning, is very dark and could be described as like port wine. And then as the day goes on, it becomes lighter, now more of a rosé. And then by the end of the day, the urine color essentially normalizes. So obviously this is not what we use today to make a diagnosis of PNH, but it does illustrate some interesting aspects of the disease that are in classic cases. The hemoglobinuria is observed, although in many cases the diagnosis does not depend on finding gross hematuria. No, next slide. So the HAMS test was developed by this gentleman. Let's see, if you'll forward it, there'll be a caption. Yeah, okay. So this is Thomas Hale Ham, and he was he is credited with discovering the link between PNH and complement. And he developed an assay that became known as HAMS test, in which acidified serum was added to the blood of patients of individuals who were suspected of having PNH. And if they had PNH, then a portion of the cells would hemolyze. So this test was developed right around 1940, when Ham was still in Boston. He subsequently moved to Case Western, where he was a very prominent hematologist, although more interested in medical education later. Anyway, so from about 1940 all the way up to the early 90s, this was the test that was used to diagnose PNH. Another test that was developed at Vanderbilt in Nashville was called the sugar water test, and that was also used in some settings. The Coombs test is not is used to look for the basis of the hemolytic anemia, but in patients with PNH, the Coombs test initially is negative. So this is the way we diagnose PNH in 2020, and actually this system has been being refined really since the early 90s. That's flow cytometry. And what you see in the left-hand panel are the controls. This is the red blood cells, and then they're stained with these antibodies against these two complement regulatory proteins, CD55 and 59. And what you see is that the red blood cells all express these two proteins. Now, if you look at the PNH patient, you see there are two populations of cells. One is like the control. It expresses CD55 and 59. And then there's this large negative population that expresses neither CD55 nor CD59. And we can do the same type of experiment for neutrophils, or diagnostic tests for neutrophils. And again, under normal neutrophils express both CD55 and CD59 in high density, whereas a patient with PNH will have a positive population and a negative population. And these are the percentage of negative cells. And you see that this 72% here for the patient, for the red cells, but 96% for the neutrophils. And the reason for that is because the PNH cells are being destroyed by complement, whereas the neutrophils, even though they're deficient in these complement regulatory proteins, they have a normal survival time. So this is the way that we determine clone size, is based on the percentage of GPI negative neutrophils or monocytes. Next slide. So now I want to talk a bit about the pathophysiology of PNH. And this is basically an outline of what I'm going to be talking about this morning. Next slide, please. Okay, yes. So if you look at where PNH is discussed in hematology textbooks, it's discussed under red cells and more specifically under hemolytic anemias. And it is certainly a hemolytic anemia, and that's the most prominent clinical feature of the disease. However, it's not just an abnormality of the red blood cell. It's actually results from a somatic mutation in a hematopoietic stem cell or progenitor cell. Next bullet. Now, another important characteristic of PNH is that it is a clonal disease, meaning all of the cells that are abnormal are derived from a clone, but this clone is not malignant. So this does not behave like acute leukemia, where the clone continues to expand and then to invade other tissues. The clone in PNH typically reaches a point of expansion that's determined by some other characteristics of the stem cell, and then it stays at that clonal size, usually indefinitely. And on top of that, we oftentimes see more than one clone in a single patient. And the basis of this, the clonal marker for this disease is somatic mutation in PIG-A. So somatic means that the mutation occurred in somatic tissues rather than in germline tissues. So this is not an inherited disease. This is an acquired disease. And the characteristic feature of the PNH cells is that, again, this occurs only in the bone marrow cells. And all of the cells that are derived from that malignant stem cell, from that mutant stem cell or progenitor cell are deficient in a group of proteins called glycosyl phosphatidylinositol anchored proteins. So, and the converse of that is, or the parallel of that is true in that any GPI anchored protein that's normally expressed on hematopoietic stem cells will be deficient in PNH. Next bullet. Now, hemolytic anemia is not the only characteristic of PNH. There's always some element of bone marrow insufficiency or failure, although the degree varies greatly among patients. And patients with PNH do have an increased risk of blood clotting or thrombophilia. So the three clinical characteristics, hemolytic anemia, bone marrow insufficiency or failure, and thrombophilia. Next slide. So this is an illustration of the types of proteins that are deficient in PNH. So this is the sort of prototypic protein. Most of the membrane proteins have this structure called a transmembrane protein, in which they have an ectoplasmic domain, and then they are anchored into the membrane by a short series of hydrophobic amino acids. And then these transmembrane proteins often have a cytoplasmic tail that has a function, a signaling function. Now, this is a striking difference between the GPI anchor protein structure. Although you can see here that the core protein portion is very similar to the ectoplasmic domain of the transmembrane protein. But the big difference here is that this moiety here, the GPI anchor moiety, is what keeps the protein in the membrane of the blood cell. And it's anchored by these fatty acid residues. And then this is the structure of the GPI anchor. This is where the defect is in PNH. The very first step in the synthesis of this anchor is defective because of mutation in PIG-A. Next slide. And this is going to be a summary slide that basically presents the pathophysiology of PNH and 150 or so years of research into a single slide. But this is an example of a normal, we can call it a red blood cell. It has transmembrane proteins. It has GPI anchored proteins. And I'm illustrating two of the GPI anchored proteins that are complement regulatory proteins, CD55 and 59. And in the case of PNH, there's a mutation in the gene PIG-A, which is an enzyme, a glycosyltransferase, that's responsible or is required to mediate this very first step in the synthetic pathway to attach the nucleotide sugar to the phosphatidylinositol. And so as a result, you do get the inositol phosphate component of the GPI anchor is present in the lipid bilayer, but the other components of the protein are not present. Next part of this slide, yes, okay, and next. So PIG-A is, so you can imagine that there are many enzymes and cofactors that are needed to synthesize this very complex anchor. But it turns out that essentially everyone with PNH has the same mutation, and that is a mutation of the PIG-A gene. And the reason for that is just straightforward mathematical reason, and that is that the gene is located on the X chromosome. So in males, there's one X chromosome. The sex chromosomes are X and Y. They have one X chromosome. And in females, there are two X chromosomes. However, very early in embryogenesis, one of those X chromosomes is inactivated. So functionally in somatic tissues, that is all tissues except the germline tissues, females have one functional X chromosome. So you only have to knock out one allele in order to inactivate the PIG-A mutation, whereas all of the other enzymes and factors involved in the synthesis of PNH are so-called autosomal genes, that is that there are two copies. Now there is a rare case in which you can get PNH for another molecular reason, but for all practical purposes, it's mutations in PIG-A. Next slide. Okay, now here's another interesting thing about PNH is that all GPI anchor proteins are deficient, not just the two complement regulatory proteins, but all GPI anchored proteins. Here's a partial list of GPI anchored proteins that have been identified on hematopoietic cells. And you can see there's a large number, and this is even a partial list. But the important thing to take away from this is that even though many proteins are missing, the only two that have been clearly demonstrated to contribute to the pathophysiology of PNH is the deficiency of CD55, which is also called decay accelerating factor, or DAF, and CD59, which is also called membrane inhibitor reactive lysis, or MERL. Despite the deficiency of many other proteins with varying functions, the cell has basically normal characteristics, except for its ability to, or its capacity to contain the activity of the alternative pathway of complement. Next slide. Okay, now we can't talk about PNH without talking about complement, although many medical students wish we could. But anyway, this is, just make this really straightforward. PNH is an abnormality of the regulation of the alternative pathway of complement. And I've illustrated the C3, C5, and C5 convertases along with the membrane attack complex. CD55 is, or DAF, is a protein that controls the stability and formation of the C3 and C5 convertases. And these are amplification pathways in which many, many molecules of C3 are activated and form of C5 convertase complex that then goes on to form the membrane attack complex of complement. And this is the part of the complex that lyses the red blood cell. And also want to mention that there's some data that also indicates that CD59 can work in the early parts of the alternative pathway complement cascade and regulate the C3 and C5 convertases as well. Now, this is a cartoon that illustrates the difference between a normal red cell that has normal amounts of CD55 and CD59. When it undergoes complement attack, these proteins are able to prevent the formation of the C3, C5 convertases and the membrane attack complex, whereas PNH cells lack these regulatory proteins. And so now the complement system, the alternative pathway, can be activated on the cell, and the terminal part of the complex basically forms a pore in the red cell. So contents of the red cell leak out, water leaks in, the water causes the cell to expand and lyse, and as a result of that, we get release of intracellular components, including LDH, which of course is a very important marker for the intravascular hemolysis of PNH. Next slide. Okay, can I have the next slide? All right, so the pathophysiology of PNH. These characteristics I want you to keep in mind because they're important and distinguish PNH from many other types of disorders. First of all, it is a clonal disorder, but it's a non-malignant clonal disorder. In addition, oftentimes, if we look hard enough, we can find that there's more than one mutant clone in a patient. And the other factor is that, again, this is an acquired disease due to a somatic mutation in PIG-A. It is not an inherited disorder. So next slide. So we have two components to the development of the disease. One is the selection of the mutant clone, and then there's the expansion of the mutant clone. Next bullet. So as opposed to acute leukemia, where the mutation in a gene like BCR-ABL in chronic myelogenous leukemia is the driver mutation that causes the clone to expand. the PIG-A mutation does not appear to provide any growth or survival advantage. In this case, next bullet point, the PIG-A mutation provides a survival advantage rather than a proliferative advantage. And so the basis of this, I'm going to illustrate this in another slide, but the basis of this is that there is something that, that when the GPI anchor proteins are missing, this gives an advantage to the PIG-A mutant stem cell that it allows it to survive immune attack in the bone marrow. Next bullet point. So this hypothesis is strongly supported by in aplastic anemia, which is a immune-mediated disease. And under these, the attack by the immune system in aplastic anemia, the PIG-A mutant stem cell has a survival advantage and is therefore selected. So you can think of this like Darwinian evolution taking place within the bone marrow. That is, that there's some mutant cells that have an advantage that when there's a selection pressure applied, become dominant. Next slide. Now I've illustrated this in a cartoon. So here's my cartoon version of this. So these green circles are normal hematopoietic stem cells and progenitor cells. And in every person, there are some PIG-A mutant stem progenitor cells, but there are very few of them, and they don't really have any impact on normal hematopoiesis. But when the bone marrow undergoes an immune attack, the normal cells are killed by the immune attack, whereas the PNH cells are protected against this immune attack. And these different colored cells means that these are different PIG-A cells. In other words, if you tease them out and sequence the PIG-A gene, you'd find that these had different PIG-A mutations. Now, once this happens, the immune attack, now the PNH cells survive, but essentially all of the normal stem cells are destroyed. And then under conditions of stress hematopoiesis, additional mutations can be acquired that provide some growth or survival advantage. So in a patient with PNH, you'll oftentimes see the clones represented in different numbers. So this clone here might expand a great deal, whereas this clone here may have very little proliferative advantage, but it does maintain its survival advantage. So this is sort of the cartoon version of how PNH is related to aplastic anemia. So the big picture is that there's something about the PIG-A mutant cells that allow them to survive in the setting of this immune attack on the bone marrow. Okay, next slide. All right, the diagnosis is our next topic of discussion. Could I have the next slide? Now, once you suspect PNH, it's extremely easy to diagnose based on flow cytometry. However, the disease is extremely heterogeneous because for two reasons. One is that the clone size varies a great deal among patients. And number two, there are some phenotypic features of the red cells that also influence the clinical manifestations. Next slide. Okay, so I'm going to introduce the flow cytometry. I've already introduced it, but I'm going to just review this. Again, this is the normal controls. If we have a small population of PNH cells, subclinical, that is that the PNH cell clone is so small that it doesn't cause any clinical manifestations. You can't even detect biochemical evidence of hemolysis in patients with subclinical PNH, but these cells are very distinct. So even when there's way less than 1% of the cells that are affected, you can still easily detect them. And again, they're more of the neutrophils than the red cells because the red cells are being destroyed selectively by complement. Next part of the slide. This is an example of another patient who has PNH, but the clone is larger. Again, there's this striking difference between the size of the neutrophil and the red cell clone. So at about 20 to 25% clone size, you can begin to see some biochemical evidence of hemolysis. And so we see this in the setting of another bone marrow failure disorder, typically aplastic anemia or low-risk MDS. But this is, again, even though the percentage of cells is very small, they're easily detectable by this very sensitive assay. Next slide. Oh yeah, these are detected using antibodies against the two complement regulatory proteins. But there's also a reagent that's now used for screening of nucleated cells, the neutrophils and the monocytes, called the FLAIR reagent. And this is used in many laboratories now as part of the diagnostic procedure. But it works the same way in that it's binding to GPI-anchored proteins, although it binds to the GPI portion rather than the protein portion of the glycoprotein. Next slide. And then this is a classic PNH. This is the patient I illustrated initially, where there's a large population of PNH cells, again, more in the neutrophil lineage than in the red cell lineage, but essentially all of the hematopoiesis in this patient is derived from the PNH clone. Next slide. Now, the other part I mentioned in addition to clone size is phenotype. That is whether or not the cells are completely or partially deficient in GPI-anchored proteins. They were named based on earlier experiments, really brilliant experiments that distinguished the sensitivity of the cells in the peripheral blood to complement. So they were called type 1, type 2, and type 3. And this nomenclature has stayed, even though we don't use the assay that Dr. Ross developed to identify them. So the type 1 cells are really the normal cells. They have normal expression of GPI-anchored proteins. The type 3 cells are completely deficient, but then we have another group of cells that have partial deficiency of GPI-anchored proteins and have different PIGA mutations. And these actually have important clinical consequences because even though they're only about 10% of the normal expression of GPI-anchored proteins, here these cells are protected against complement lysis, except when there's brisk activation of the complement system. And next slide. this is a photograph of Dr. Ross, who I trained with at Duke. And there's another little part of this slide that just recognizes Dr. Ross and he was really the one who identified the different phenotypes and also the one who identified the defect in complement control and on PNH cells. Next slide. This is to illustrate the different phenotypes. Let's just look at this over on the right-hand panel. If we look at the control, we see a nice Gaussian distribution of the CD59 protein. If we look at this is one patient with PNH, and what we see is a mosaic of cells. So they're not all alike. So you do have some leftover normal cells, but then you have two different PNH type cells, one of which is completely deficient in GPI anchor protein expression and one that is partially deficient. Another important thing to pay attention to is that this is a log scale. So this actually has only 10% of the normal amount of GPI anchor protein or CD59 protein, whereas of course the type 3s are completely deficient. This has another part to it. Yeah. So the idea here is that there's a threshold at which the cells are selected for, have clonal selection. So in other words, there has to be, these cells have to be 90% or more deficient in GPI anchor proteins in order for them to have that selective advantage that allows them to survive the immune attack. And again, if we tease this out in a very precise way, what we can find is that even though these have the same phenotype, this is especially true for the PNH3 cells, they have different PIGA genotypes. So you can imagine if the mutation is such that it completely inactivates the gene, no matter what the mutation is, it'll show up as a type 3 phenotype. Whereas these type 2 cells are derived from stem cells that have partial inactivation of the enzyme function. Next slide. And again, this has some clinical importance. If you have, this is the most typical picture that we see, that is the peripheral blood is a mosaic of type 3s and type 1s. So these are, if you have classic PNH, you have a large population of type 3 cells in which there's brisk intravascular hemolysis. You could also have a phenotype here where you had, that was illustrated earlier, where you have a large population of type 2 cells, a smaller population of normal cells, and then some type 3 cells. Now in this case, what we see is very little hemolysis because the type 2 cells, even though there's a large clone, there's enough of the complement regulatory proteins on these cells to prevent spontaneous complement-mediated hemolysis. So these are picked up, these patients with mainly type 2s are seen when the complement system is briskly activated. And then this is the one where we have a small population of type 3 cells and a large population of type 1s. There's very little hemolysis in these cases. And so in this case, the PNH clone is not causing any problems in and of itself, but it is a marker for immune-mediated bone marrow failure. Next slide. Okay, so management of PNH is next. And if I could have the next slide. So the basic evaluation is really very straightforward, that if we suspect PNH, We send a sample of the peripheral blood for flow cytometry. We check for the blood counts to see if there are any deficiencies of any of the cell lineages, including the white cells, the platelets, and the red cells. The reticulocyte count is very important because that tells us how well the bone marrow is trying to compensate for the anemia. And then, of course, we have some biochemical markers, the most important of which is the LDH. That's our marker for intravascular hemolysis. There are other markers that can be seen in intra and extravascular hemolysis. And we do check iron stores because the constant hemoglobinuria can cause iron deficiency. We want to look at the bone marrow to analyze both the morphology of the bone marrow and also to determine the degree of cellularity within the bone marrow. And this can help us in distinguishing classic PNH from other forms of the disease that are associated with other bone marrow failure syndromes, particularly low-grade MDS and aplastic anemia. Next slide. So this is the way we classify PNH. This is based on a classification that was developed with the PNH interest group, that essentially assigns three subcategories of PNH. The classic PNH, which is the one that most people think of when they think of PNH, as being a brisk hemolytic anemia, but we also see PNH in the setting of other bone marrow failure syndromes. Oftentimes the PNH clone is relatively small in size and causes little in the way of hemolysis, but it serves again as a marker for immune-mediated bone marrow failure. And then the subclinical form, the clones are very small. They're so small that they don't produce biochemical or clinical evidence of intravascular hemolysis, but they act as an important marker for immune-mediated bone marrow failure. Next slide. Okay, so this association between PNH and aplastic anemia has been noted for more than 50 years, was originally identified by Dacey, Sir John Dacey, who was a real pioneer in the field. Then later, as very sensitive flow cytometry became available, this link was tightened even further to demonstrate that somewhere around 50% of all patients with aplastic anemia will have some identifiable PNH clone. And then this relationship with low-risk MDS is a fairly recent observation. Shinji Nakao and his colleagues in Japan were really the ones who identified this association with low-risk MDS. And then, of course, PNH, subclinical PNH is a new phenomenon. Again, we owe much of the discovery part of this to Dr. Nakao's group, who showed that using very high sensitivity flow cytometry, that you could identify these very small clones in patients with immune-mediated bone marrow failure. Next slide. And this is just to illustrate the relationship between PNH and bone marrow failure syndrome. So here we have classic PNH, and this is the clone size. You have to have a clone size of at least about 25% in order to see clinical manifestations of PNH. Now, in his study, and this is a large group of 750 patients, he found that 49% of patients had an identifiable PNH clone. Now, what you do see is that these clones tend to be very small. And here, the median clone size is well under 1%, 0.239. Now, the case with MDS, refractory anemia, refractory cytopenias with multilineage dysplasia, the percentage is smaller. So his group found about 17%. So these have held up with other studies as well. So somewhere around half of the patients with aplastic anemia will have a PNH, small PNH clone, and about 15 to 20% in low-risk MDS. And the other thing that's important is that, again, the vast majority of these are subclinical. Again, you have to get up to this somewhere around the 90th percentile in order to see any clinical manifestations. So there's another part to this slide that just shows that this is where you see clinical PNH, and then this is highly specific for these types of bone marrow failure, because if you look at other types of bone marrow failure and other non-malignant diseases, you do not find any GPI anchored proteins, even small clones. Next slide. So the point here is that even though these clones are small, they're important to discover because they serve as a surrogate marker for immune-mediated pathology in both aplastic anemia and low-risk MDS. And this finding these PNH clones is important therapeutically because there's a favorable response to immune suppression in patients with bone marrow failure who have a PNH clone. Next slide. The classification has a big impact on how we manage patients. If there's subclinical PNH, then the focus really is on the bone marrow failure. The PNH component is not important in terms of therapy, but is important as a marker. But the focus is on the nature of the bone marrow failure. Next part of the slide. And then we have the situation where we have PNH in the setting of a defined bone marrow failure, aplastic anemia, and low-risk MDS. And again, having this PNH clone is not as important for management, but for treatment of PNH, but rather is a marker for immune-mediated bone marrow failure that's responsive to immunosuppressive therapy. Now, having said that, about half of these patients, half of the patients who have PNH and bone marrow failure where the clone is large enough to cause at least some biochemical evidence of hemolysis, about half of patients will require some PNH therapy, either complement inhibitory therapy or anticoagulation therapy. And then the final category is classic PNH. And that's the one that where there's a large PNH clone, and the symptoms come from the PNH clone, the lethargy, malaise, fatigue, the symptoms of intravascular hemolysis. And this is very responsive to treatment with complement inhibitory therapy such as eculizumab or ravulizumab, Ultomiris. Next slide. So here are the treatments. This is the antibody. This is eculizumab. So it's a humanized monoclonal antibody that binds to the fifth component of complement and blocks formation of the membrane attack complex and prevents hemolysis in that way. This has another part, that slide. Could you show the, right, this just reminds people, I know the audience's experience, that patients have to be vaccinated against Neisseria because absence of the terminal complement components increases the risk for Neisseria infections. So the treatment schedule is a loading dose followed by every 2-week treatment. And of course, many patients now are on a longer acting version of this same inhibitor called ravulizumab or Ultomiris. These are generally very well tolerated, but treatment needs to be continuous because they're not treating the underlying disease, but rather treating a symptom, that is the hemolysis. Next slide. And this is just to illustrate how this works. Again, this has another part. This is where eculizumab works to block C5 and prevent formation of this membrane attack complex. Okay, now, one thing that happens when you block the membrane attack complex is that because there are two defects in PNH, you're blocking the membrane attack complex formation, but you're not inhibiting the C3 convertase and C5 convertase formation. So the consequence of that is that the red blood cell, now that you block the hemolysis of the PNH red blood cell, it becomes opsonized with components of C3. And these components of C3 are recognized by phagocytic cells of the reticuloendothelial cells. They have receptors for various fragments of activated complement, including IC3B and C3DG. And so patients with PNH who are treated with these complement, with eculizumab or ravulizumab can continue to have extravascular hemolysis that's mediated by these C3 opsonins. Next slide. So what does eculizumab do? It's highly effective in blocking the intravascular hemolysis of PNH, and along with that, most of the symptoms of the intravascular hemolysis resolve. So the symptoms of malaise, fatigue, lethargy, this sort of weakness or lack of energy, dysphagia, difficulty swallowing or painful swallowing, and male impotence. These are all due to the intravascular hemolysis, and these are extremely well controlled with these complements, the C5 complement inhibitors. It also reduces transfusion requirements such that about 65% of patients become transfusion independent. And in those patients who don't become transfusion independent, it prolongs the interval between transfusions. It also reduces the risk of thrombosis. So even though these are retrospective types of studies, the evidence is quite compelling that it is effective in inhibiting thrombotic risk as well. And this is almost certainly due to its effects on intravascular hemolysis. Next slide. Now, what doesn't it do? As I showed before, it doesn't prevent the opsonization and extravascular hemolysis, and the extent to which that's clinically significant varies a great deal among patients, and we'll talk about that a little bit more in just a minute. The important thing to remember is that it does not do anything for the underlying disease. In other words, you're just treating symptoms of the disease that are caused by the complement-mediated hemolysis. But the bone marrow failure persists, the clonal hematopoiesis persists, and the reason that this is effective long-term is because PNH does not progress into a malignant disease. And so even though you're not treating the underlying disease, it's effective therapy because the clone itself remains non-malignant. Next slide. So survival of patients, this is a study that was published a few years ago now, but it's been confirmed in other studies from other centers. So if you look at patients with classic PNH who are treated with eculizumab and you compare survival to a group of age sex-matched controls, what you see is that the survival is identical to age sex-matched controls. Next slide. And this is the reason that PNH treatment with bone marrow failure is curative treatment, but it's used less frequently now because the management of the hemolytic, particularly the hemolytic aspect of PNH, can be managed without transplant. And so there's reluctance to transplant by the transplant physicians because this is a non-malignant disease that does have an effective alternative therapy. So even though you can cure PNH with transplant, there's the risk of mortality due to transplant-related complications and also long-term morbidity, mainly due to graft versus host disease. Next slide. And finally, what's on the horizon for treatment of PNH? And I think many of you have heard about some of these other treatments. Obviously, we talked about Ultomiris that was approved in December of 2018. It's basically a long-acting form of eculizumab, and it's so-called non-inferior to revulizumab. I'm sorry, to eculizumab, but it's much more convenient because it can be given every 8 weeks instead of every 2 weeks. So many patients appreciate that and have switched over because of that. There are other C5 inhibitors that are also under development that are administered in a different way. For example, subcutaneous forms that are long-acting are under development. And so there'll be options that'll be available over the next few years as a different way of inhibiting C5 using subcutaneous, long-acting subcutaneous injections. Next slide. This is just some examples of some other C5. And the other place to attack this is to try to prevent the extravascular hemolysis due to C3 opsonization. Next slide. And then next component of this. Yeah. So I think we'll given the time, let's go ahead and move forward. Okay, and so I'm just illustrating this because there's a lot of interest in trying to block the C3 convertase. And some of you I know have heard of Apellis. This is the one that's furthest along in clinical development. It directly inhibits C3. And then there are other very interesting inhibitors that are targeting different parts of the C3 convertase, including factor D and factor B. These are in clinical trials in humans, and we expect that we'll know much more about their safety and efficacy. And some of these are oral treatments, so they're pills that can be taken once or twice a day that will have the potential to act as monotherapy to treat PNH. So there's a lot of exciting things on the horizon for treatment options. Next slide. This is the end, and this is kind of my COVID joke that even though we try these measures, the Grim Reaper, the COVID virus, is still out there. Okay, I'm sorry I ran over a little bit in terms of time. I didn't leave enough time for to wrap things up, but anyway, I'll be glad to answer any questions after
Thanks, Dr. Parker. We have a few questions. Our first question is, in a recovered severe aplastic anemia patient, would you recommend monitoring the progression of PNH clones as an early indicator of relapse, for which earlier intervention of immunosuppressive therapy would be beneficial?
Yes, that's a very good question. So typically, the natural history of the PNH clone is that there is the clone typically does not progress in size. And usually with immunosuppressive therapy, the clone does not become smaller and almost never goes away completely. So using that as a marker for progressive disease, especially in the immune-mediated bone marrow failure component of the disease, it does not serve as a valuable marker for disease progression. So we do monitor the clone, but and I think if there was clear evidence of clonal expansion, then that would alert you to keep a closer eye on the clone, but would not necessarily be an indication to reinitiate immunosuppressive therapy. That's really based more on the clinical manifestations of the aplastic anemia. That is the degree of the anemia, thrombocytopenia, and leukopenia. Those are the things that are going to determine treatment.
Thank you. Would PNH be considered as a myeloid disease?
No, it's considered a disease of the hematopoietic stem progenitor cells. So if you look hard into the lymphocyte lineage, you will find the same mutations in the lymphocyte lineage. Now that doesn't always occur because the somatic event may take place later in a progenitor cell that has differentiated along myeloid lineages, but it's best to think of it as a stem cell disorder and rather than a myeloid or a lymphoid disorder. And so that's the way I think of it, as a stem cell, early progenitor cell disorder.
Thank you. Can a patient with very severe aplastic anemia have PNH symptoms such as dark urine at night and abdominal cramps, but shows up on blood tests such as flow cytometry that they do not have PNH?
No, those clinical symptoms that you're describing are due to intravascular hemolysis. So if that were due to PNH, then it would be very evident on the flow cytometry that there was abnormal population. Like I said, you don't begin to see clinical manifestations until the clone size reaches somewhere in the range of 25% based on GPI deficient neutrophils or monocytes. Are there other questions?
Yes, I'm sorry. Is it normal to do nothing when you had aplastic anemia and PNH with a 51% clone size?
So that falls into that group. If you remember the second group with PNH and bone marrow failure, where you have clinically significant clone, as I said, about 50% of patients who fall into that category will require some PNH-specific therapy, either anticoagulant therapy or complement inhibitory therapy. So I can imagine a scenario where there was a 50% clone in the setting of bone marrow failure where the PNH component was not thought to be clinically significant. So yes, I can see a scenario where that could happen. Although, again, typically with a clone size of 50%, there is at least biochemical evidence of hemolysis, although there may not be clinical evidence. So that would be really a judgment call by the treating physician as to whether or not they thought that the symptoms that the patient was having were due to PNH, to intravascular hemolysis.
Thank you. Should all aplastic anemia patients be tested for PNH? And if so, how often?
Yes, I believe all patients should be tested. And again, the reason is because there's a growing body of evidence, and I think that's reaching a consensus that if a PNH clone is present, then it is a surrogate marker for immune-mediated bone marrow failure. And so that would direct treatment of patients to find the PNH clone present. So yes, I believe all patients with aplastic anemia should be screened for PNH. And in my practice, if I have a patient with aplastic anemia who does not have a PNH clone at presentation, I screen yearly for the appearance of a PNH clone, because it's clear that patients can develop PNH or clinically significant PNH years after treatment for aplastic anemia. So we do screen patients on a yearly basis, and sooner if they develop symptoms that are thought to be due to PNH.
Thank you. If an aplastic anemia patient has a successful bone marrow transplant, should they still be tested for PNH later?
So that is a good question. So typically the bone marrow transplant eradicates the PNH clone as well as the other stem cells. And it's extremely rare for that PNH clone to recur. Now, having said that, there are anecdotal reports of the PNH clone recurring, but under those circumstances, usually the clone is extremely small and does not produce any clinical manifestations and is not in and of itself a basis for additional treatment. So I think either way is acceptable because it's such a rare event to see the clone recur once it's eradicated by bone marrow transplant. It's not unreasonable not to look for recurrent, for the clone to come back. On the other hand, if there's an interest in trying to understand the pathophysiology better, then following the clone recurrence is a reasonable idea. And actually distinguishing whether or not the clone comes from the donor or from the patient also has some interest. In cases where the clone has recurred, and there are very few of these, the ones that have been analyzed have come from the patient rather than from the donor. Again, these are extremely rare events.
Last question is, can you address implications of subclinical PNH clones in the presence of bone marrow failure?
I'm sorry, repeat that again.
Sure. Can you address implications of clinical PNH clones in the presence of bone marrow failure?
Okay, so yes, in the setting of bone marrow failure, the presence of a PNH clone indicates that the bone marrow failure is an immune-mediated process. So in that setting, again, if the bone marrow failure is MDS or aplastic anemia, that does have clinical implications because of the evidence that in that setting, the probability of responding to immunosuppressive therapy is higher than if a PNH clone is not present. Now, having said that, I said that there's a near consensus among people in the field that that's the case. Not all the evidence supports that. Although some more recent evidence showing that 6P LOH, loss of heterozygosity on the HLA locus, is also found in patients with aplastic anemia. This further supports the idea of an immune-mediated mechanism, which again points toward response to therapy with immunosuppressive agents. So yes, it is important to identify that clone in bone marrow failure.
Thank you so much, Dr. Parker, for sharing your time and your expertise with all of us today. If you would like to watch this webinar again at a later time, it will be available on our website within 2 to 3 business days. If we were not able to get to your question today, you can send it to us in 3 ways. Send an email to help@aamds.org, call our helpline at 800-747-2820, extension 2, or submit a question on our Facebook page. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to support you and your family as we have done for the past 36 years. This concludes today's program. Thank you, Dr. Parker.
Thank you. It's been my pleasure, and good luck to everyone. Please stay safe.